after acute reperfusion treatment, which is IV thrombolytic and endovascular intervention, mechanical thrombectomy. The second point is antiplatelet agent. Antiplatelet, we use in acute ischemic stroke only one antiplatelet to reduce risk of recurrent of ischemic stroke. If we use intravenous thrombolytic therapy, we should withhold for at least 24 hours and start antiplatelet later on. If there is failure of aspirin, which is widely used nowadays in treatment of acute ischemic stroke, and the patient on aspirin and he developed a new stroke, there should be changed into another antiplatelet, clopidogrel. If clopidogrel or aspirin both is failed, so we can combine the pyridamole previously used as monotherapy, now only added to aspirin or clopidogrel for treatment of stroke. Anticoagulant. There is no clear benefit of anticoagulant over antiplatelet therapy. There is no evidence prove that there is superiority for anticoagulant in treatment of acute stroke, except there is an exception, and as the English said, the exceptions make the rule. Traditionally, we don't use anticoagulant, but in special situation, we have to use the anticoagulant. What is this special situation? If there is a clear source of emboli that induce the stroke, for example, the myocardial infarction, the patient with atrial fibrillation. For myocardial infarction, we use anticoagulant 3 months post the attack. Atrial dissection is another condition that we should use anticoagulant because it's superior to antiplatelet, and use it for maybe up to 6 months. Not always we have limited to a special period, because sometimes, for example, the patient will have atrial fibrillation and the condition persists, so you should have persistent of the use of anticoagulant. Nowadays, we use the novel oral anticoagulant, non-vitamin K anticoagulant. It's superior to the old generation anticoagulant in different way. Fixed dosing, rapid onset of action, few drug interaction, no dietary restriction needed with it, with the novel anticoagulant, lack of laboratory monitoring, and this is very important. And maybe the most important factor is that the rate of change to transformation to hemorrhagic infarction is very low with novel anticoagulant over the old one, warfarin. يعني honestly يعني هو ما يصير يمكن اقولها، بس I hate warfarin لانه يعني المونيتورنج is very difficult. Our patient he need يعني close contact، طبعا يعني close monitoring for that، وهذه صعبه يسويها. يعني what we said nowadays the novel anticoagulant is costly. No، اذا حسبنا المونيتورنج، the cost of the monitoring, it will be يعني nearly the same. Anti-edema agent, which is widely used in the past, nowadays it's only for limited, and it's not rewarding in ischemic stroke, because the ischemia is cytotoxic, and anti-edema agents difficult to interfere with this kind of edema. Antihypertensive agent or treatment of hypertension in ischemic stroke. This item has a paramount importance concepts in treatment of hypertension, because it may aggravate the condition, may expand the stroke rather than to treat the patient. All of us know that hypertension may be the most common risk factor of stroke, but it doesn't mean reducing blood pressure in acute stage of stroke is rewarding in treatment of this condition. It doesn't mean يعني هي مو انه hypertension cause stroke okay treat hypertension it means treat stroke. مو هيك المسألة. In acute stage of stroke, hypertension and elevated blood pressure is something like defense mechanism. There is something called cerebral autoregulation. So the terms of this cerebral autoregulation may raise the blood pressure in the first 10 days more than its mean. So blood pressure should be lower if there is extremely elevated value on repeated measurement. I will repeat, the repeated measurement is not at the scene. If you encounter a patient at the time of admission to the RCU with high blood pressure, it doesn't mean you should interfere at once. With repeated measures, there is no general agreement about how long, but in a way or another, it is around 6 hours. What is the measure that we should interfere in ischemic stroke? It is above, the systolic above 220 and diastolic above 120. Okay. Blood pressure should be less than 180 over 110 millimeter mercury before thrombolysis, but it doesn't mean to lower it in anyhow. Lower blood pressure by 15% during the first 24 hours can be achieved with intravenous labetalol nicardipine. So it's not allowed to decrease blood pressure more than 15%. This will be, in the previous item, you say you cannot use a thrombolysis if there is blood pressure 185 over 110. Yes, this will be contraindication to use this mode of treatment and shift the patient toward endovascular intervention. If the patient on antihypertensive agent previously continue with the same dose, اجى قال لك اني يعني خليني على اتاكاند 8 يمكن تشوف 8 قليل. It's okay, fine. Continue with the same dose for the first 10 days. After the 10 days, we have a new start to treatment hypertension in this patient. Statin, lipid lowering agent. Nowadays, there's a clear evidence that the evidence have a clear conclusion that statin with antiplatelet is powerful than antiplatelet alone, to all patients with possible atherosclerotic contribution. But you should remember, if the patient not on statin initially and have stroke, better to, طبعا الانجليز ما يقولون better, يقولون should be. I think it should be يعني start statin after 48 hours from the onset. يعني even in our situation احنا ما عندنا يعني يمكن بدنا نستخدم الثرومبوليتيك only for limited situation. Even so, you should start statin after 48 hours from the onset. Start antiplatelet, but after. Why? Because the possibility for hemorrhagic transformation is very high if you started in the يعني in the first few hours. يعني honestly, I يعني came across 2 patients with ischemic stroke, and somebody starts statin in the first few hours in combination with antiplatelet. وبالمناسبه اكو الهنود سووا كومبينيشن، يعني تلقاه بالسوق هو كومبينيشن ستاتين with antiplatelet. يعني I don't want to say disaster but something incorrect. خلينا نكون دبلوماسيين. If you start in the first hours, I encountered 2 patients with hemorrhagic transformation. One of them, male and female, died. What is the role of surgery in treatment of acute ischemic stroke? If there is posterior fossa posterior circulation stroke, and maybe there is compression of the brainstem, say due to cerebellar infarction, you should have posterior fossa decompression. In middle, if you remember in last lecture, I display a CT scan for ischemia of all the middle cerebral artery supplied area. If there is edema in this area, you should send the patient for decompressive hemicraniectomy to which is performed in the first 48 hours rapidly to alleviate the possibility of herniation. And honestly, herniation, it means death in this situation. Regarding the carotid artery stenosis, I will repeat it. All the patients with TIA and minor stroke, non-disabling stroke, should have carotid urgent carotid imaging. Why? Yani disabling stroke, what happened is happened. But in TIA and minor stroke, my job, my aim of treatment is to prevent change to disabling stroke. So urgently, I should have imaging for the carotid. If there is stenosis more than 80%, the patient should have extracranial arterectomy and carotid stenting. One of them. This is 2 methods of treatment of carotid stenosis. Why? Sorry, before why? We should do it in the first 14 days, because the possibility to have another stroke in the 14 days with carotid stenosis is very, very high. So to prevent that, we should send the patient, the cardiovascular surgeon, to do endarterectomy or carotid at least carotid stenting. In asymptomatic patient, this is maybe related to this, directly to this lecture, but if the same patient with no TIA, no this minor stroke, but found to be a case of cardiac stenosis, this patient treated with antiplatelet and statin. يعني افتهمنا بالمحاضرة متأخرين والطريقة، بس ما أدري ما هو وصلت حكيت أنا آخر شيء. Treatment will be antiplatelet. مو يعني والله هذا الدخول ترى هسه هم دخل واحد. Symptomatic as any يعني as our strategy is to prevent further attack, it will be the aim to be prevent stroke in those patients asymptomatic. So the treatment is antiplatelet plus statin. But if the obstruction, if the stenosis of the cardiac artery is more than 70%, maybe up to 99%, I think and most of the authors think that surgery is indicated. General measure, supportive measure is very important. Regardless of stroke etiology, the primary goal of hospitalizing all affected patients is the prevention and treatment of associated medical and neurological complications. First of all, prevention of deep venous thrombosis and pulmonary embolism, because it may be the cause of death in this patient rather than the stroke itself. All stroke patients should have their hydration status assessed, monitored, and managed throughout their hospital admission. Usually, the fluid of choice is the crystalloid solution rather than colloid solution. All stroke patients have their blood glucose level monitored in the first 72 hours following admission. This is maybe appropriate for ischemic and for hemorrhagic. Hyperglycemia best to prevent the complication. But if the complication has happened, or even if the patient referred from other hospital and complication started, especially in our hospital because tertiary hospital, رجعتهم الحالة ويجزونا. If the patient with complication should be treated, hypoxia, sepsis, epileptic seizure, metabolic abnormality. In patient with cerebellar infarction, there is a possibility that the patient may develop hydrocephalus later on, and may have a benefit from insertion or of a shunt. This is for acute ischemic stroke. We have another subject, which is a global cerebral ischemia. We define the stroke as vascular insult due to focal vascular insult. But global cerebral ischemia is something different. This special situation and treatment is a different way. At least we shed a light on this subject. What is the definition of the global cerebral ischemia? And before definition, I want to remember something in the neuroanatomy. You remember something called circle of Willis. What is circle of Willis? Maybe the brain is unique to have a connection between anterior circulation and posterior circulation between the right and the left. So it's something the brain is capable to adapt any deficiency in blood supply. But if the patient develop global ischemia, which is ischemia occur when the blood flow is inadequate to meet the metabolic requirement of the brain, as in cardiac arrest. This is not focal. The blood which reaches the brain is not adequate anymore. It divided into two types: complete interruption, usually in complete interruption in a situation like cardiac arrest, and in less profound hypotension for longer period, it will be like in this diagram, watershed infarction. If it is complete interruption, it will be complete ischemia. But if it is for a long time, it will be what we call it watershed. What do you mean by watershed? Watershed is the area between anterior cerebral artery and middle cerebral artery. Between the posterior cerebral artery, area supplied by posterior cerebral artery, and area supplied by middle cerebral artery. This is what in normal situation supplied in both sides. This is the area that's supplied from the anterior cerebral artery and middle cerebral artery. But if the anterior and middle cerebral artery have inadequate blood, so it will supply only the core and leave the periphery. And the same for anterior, and the periphery for both become infarcted. This is called watershed infarction. There is a special situation which is unilateral watershed infarction. How can that? What is the big deal for behind that? How can the circle of Willis is an anastomosis of the right and the left, anterior and posterior? How can a patient have only one side watershed? This is in a special situation. We encounter this situation 2 weeks ago. Non-competent circle of Willis. In this patient, there is initially a defect in the circle of Willis that when a patient with a long time have inadequate blood appeared only in that side of the initial insult. You understand that? This is a few words about global ischemic stroke. The other kind of stroke ايه عيني
هذا البيشنت اللي قلت عليه الموربيديتي مالته يعني احسن لو اسوأ؟
which one؟
اللي هو قلت عنده incompetent circle of Willis.
يعني if you compare this patient with acute ischemic stroke, هي the prognosis of يعني prognosis of ischemic stroke depend on the site, even not the size, the site of the illness. This site ايه يعني
يعني
this site usually prognosis better from يعني perspective of mortality. Definitely this site have no but if you compare that with posterior circulation, something different. It depends on the site. This site the prognosis definitely better. طبعا مدام سالتي العاد this patient usually تحكين على bilateral watershed لو unilateral؟
هو أنا يعني بدي أسأل بصورة
أوكي.
عامة إنه هو هذا اللي عنده incompetence
لا بس
يعني.
بدي احكي bilateral watershed ينطينا clinical weakness rather than distal weakness، فكانه واحد خلي برميل ما يقدر يحرك ايده، ما يقدر يفتحها، يعني cannot abduct. This by the way يعني هاي فوق البيع عادي، نعطيكم اياها المعلومه. اوكي I will start with العفو
شكرا دكتور.
intracerebral hemorrhage. This is the second type. As I mentioned in the first lecture, stroke is a syndrome, have types and subtypes, risk factor and complications. So the second type of stroke is intracerebral hemorrhage. Intracerebral hemorrhage arises when, by the way, we say intracerebral hemorrhage even if the hemorrhage in the posterior circulation, in the brain stem. This is a term. يعني it doesn't mean intracerebral in the cerebrum. يعني intracerebral it means the brain, cerebrum and the brain stem. Intracerebral hemorrhage arises when the blood vessel within the brain ruptured and blood leak out to form a hematoma. Because the skull is fixed in volume and is completely filled with brain, blood-brain must necessarily compress, distort, and disrupt surrounding brain structure. Look for this hematoma. This is the clot, really, not the blood. So this is the rapid forming space-occupying lesion, and the brain occupied in the skull. Fixed. This is bone. It's not like in the abdomen. And the mass in the abdomen may reach the large size to be felt by the patient and by the physician. This is a closed area. So any rapid forming, rapid forming space occupying region usually compress, distort, and disrupt, and not content to this level. The damage will be by hematoma itself and by the toxic effect of the blood on the brain tissue. Blood hypertension is the one of the risk factor in intracerebral hemorrhage. We divided the intracerebral hemorrhage into hypertensive and non-hypertensive. Although non-hypertensive have enormous etiologies, but nevertheless, still hypertensive is the majority of the cases hypertensive. Maybe there is a wrong concept that hypertensive cause hemorrhagic stroke more than ischemia. No, definitely no. 80% of hypertensive, if they develop stroke, it will be ischemic stroke. The minority develop hemorrhagic stroke. But if we take the cases of intracerebral hemorrhage, most of the patients with intracerebral hemorrhage have their risk factor, the etiology is hypertension. So I will take hypertensive hemorrhage in detail. And this the pathogenesis of the hypertension will differentiate this type of intracerebral hemorrhage from other causes. Pathogenesis in hypertension divided into pathogens in hypertensive hemorrhage divided two types: chronic hypertension and acute hypertension. In chronic hypertension, the deep-seated arteries, those supplied the thalamus and basal ganglia here in the brain. Do you recognize the arrow? شوفوه.
نعم دكتور.
Okay. In this area, they develop what we call it Charcot-Bochard aneurysm. This aneurysm, if it is ruptured, will cause intracerebral hemorrhage. This is in a chronic. Since the site is deep and very and near the ventricles, it may pass to the ventricles, and the clot may obstruct CSF flow and cause hydrocephalus. In turn, the acute hypertension. Acute hypertension may precipitate intracerebral hemorrhage in a chronic hypertension. Yani acute elevation in patient with a chronic hypertension who develop Charcot-Bochard aneurysm. يعني الانيوريزم present there. تريد لها حجه to rupture. يجي acute hypertension so to precipitate the deep intracerebral hemorrhage. In other hand, rapid elevation of blood pressure, even in non-hypertensive, may precipitate intracerebral hemorrhage. يعني no history of hypertension. Maybe the patient not no, he's hypertensive. He's not hypertensive definitely, and precipitate by acute hypertension in minority of the cases with hypertensive hemorrhage. The majority was diagnosed case of hypertension for a long time, for years, and then they develop acute hemorrhagic stroke.
دكتور هنا شنو سبب الاكيوت هايبرتنشن؟
Pheochromocytoma, for example, يعني drugs sometimes can cause that, precipitate that. يعني sometimes anesthetic drug, post anesthesia يصيرون intracerebral hemorrhage. Pheochromocytoma, one of the known causes for that. يعني any cause of hypertension, rapid elevation can cause that. Okay. What is the clinical feature, characteristic clinical feature of intracerebral hemorrhage? As I mentioned in the last lecture and maybe in the first lecture, stroke is an example for a neurological condition that you cannot cannot answer the question, what is the lesion, depending on the history alone. And even there is characteristic clinical features in intracerebral hemorrhage, we cannot say 100%. So neuroimaging, and in this situation, CT scan is enough, is mandatory to prove that this is hemorrhagic stroke. Unlike ischemic stroke, intracerebral hemorrhage tend to cause the triad of headache, vomiting, and disturbance of consciousness, at least albeit for a short period, as well as a focal neurological deficit depending on the site of the hemorrhage. Blood pressure is elevated after hemorrhage. يعني the patient, okay, hypertensive, diagnosed as, but elevation of a blood pressure due to disturbance of cerebral auto regulation is mandatory in patient with hemorrhagic stroke, and normal blood pressure measuring in the casualty at time of presentation, or not even maybe not in the casualty, at the scene, anywhere, normal blood pressure exclude the possibility of hypertensive hemorrhage, even if the patient have the hemorrhage in this site. يعني لو if you look to this figure, which is a classical systemic hemorrhage, a classical for hypertensive, okay, and the patient is hypertensive, maybe controlled, but the blood pressure was in the casualty 130/80. Try to find another etiology. It cannot be, definitely. Hypertensive intracranial is unlikely before the age of 50, even in hypertensive patient, because it needs a long time to have for hypertension to cause to induce the aneurysm, for heart aneurysm. This is an example of a case, a 24-year-old man who was reasonably well and healthy, presented with headache and disturbance of consciousness for a few hours. His wife said that he took his blood pressure and was 110/80 in the last week. As far as she knows, he is on no medication or illicit drug, no history of head trauma. Examination revealed a young, drowsy man and a left upgoing plantar. Non-contrast brain CT showed a rounded lobar hyperdense lesion in the right hemisphere with mild surrounding edema. His lab tests were normal. This is definitely not a case of hypertensive intracerebral hemorrhage. So, if the patient is lobar, here is not only lobar, it is cortical. It reaches the cortex. This is not the classical area of hypertensive hemorrhage. But you should know, you should put in mind, and hypertensive hemorrhage is not necessarily in the deep area, in the basal ganglia, not necessarily to be deep hemorrhage, in the basal ganglia and thalamus. Maybe it is lobar, but in general, in lobar hemorrhage, we should search for another cause. This is the causes of lobar hemorrhage. Many causes. ما كنت أقرأها. زين. Infectious like malaria, and infective endocarditis, trauma, vascular malformation, drugs, anticoagulant, hereditary, maybe, etc. Yani if we ask the classical question, when do we suspect non-hypertensive hemorrhage, it will be if the hemorrhage is lobar and blood pressure is normal at time of presentation. What is the medical measurement for medical measures in treatment of patient with hypertensive intracerebral hemorrhage, and maybe non-hypertensive in lobar hemorrhage? Medical measures is limited, and again, hypertension treatment is crucial. But you should remember, treatment of hypertension in intracerebral hemorrhage is different from treatment of hypertension in ischemic stroke. Yes, we should lower the blood pressure and maybe aggressively more than an ischemic stroke, but is not always the case. Attempt to lower blood pressure may be compromise the cerebral blood flow and lead to infarction, but continued hypertension may exacerbate cerebral edema. This is in ischemia. In hemorrhage, sorry. In ischemia, something different. Okay. So the measure is different to interfere. We are not allowed blood pressure to be more than 185 systolic over 115 diastolic. The target is lower than that of the ischemia. Is systolic blood pressure 140. Maybe I didn't mention something about repeat because there is no agreement about that. يعني يمكن قبل يعني ايامها متناقشنا بالرجحه فهم رجعنا. One of the residents interfere within 1.5 hours from the onset. أنا الحقيقة against that. But many authors accept that. يعني in ischemic stroke, you should wait. You should repeat blood pressure for 6 hours and interfere. Why we wait for 6 hours or 2 hours, 3 hours? Because maybe this is acute elevation, something like defense mechanism, and will return back within a few hours by itself. If you lower it aggressively, it will be sudden severe hypotension that aggravate, that expand the infarction or even their hemorrhage. So in hemorrhage, some said you should interfere at the time of presentation. Some said no, you should wait. I think يعني أنا ما كاتب لكم إياه بالمحاضرة. This is my opinion. As far as I concern, I advise to wait. My recommendation to wait 3 hours. To wait, not to leave the patient, but to prepare everything, but start to interfere after 3 hours of the onset, not a presentation to the casualty. By nicardipine and labetalol like in ischemia, but nitrate should be avoided. Nitrate cause elevate intracranial pressure. So administration of nitrate will aggravate the condition rather than treat the patient. Anti-edema agent may provide temporary benefit because there is element of vasogenic edema in intracerebral hemorrhage, not like that of ischemia. In patients with vitamin K antagonist associated intracerebral hemorrhage, like in warfarin, fresh frozen plasma, vitamin K are recommended. I think fresh frozen plasma is preferable to vitamin K in this way, because vitamin K يعني act for a long time, and maybe there is indication for anticoagulant, and we should restart anticoagulant later on. Statin associated with increased risk of hemorrhagic stroke. So it is contraindicated. In the contrary to the ischemic stroke, it is contraindicated in intracerebral hemorrhage. Surgical measure. If the patient intend to be a case of herniation, that we have decompressive measurement. In cerebellar hemorrhage, because cerebellar hemorrhage compress the brain stem and may lead to death, decompression is indicated. For aneurysm, there is two kind of treatment with special indications. إذا الأخوان neurosurgery will describe that later on. Clipping or endovascular coiling, and each one have its special indication. For arteriovenous malformation as a cause of this intracellular hemorrhage, nowadays we have what we call it gamma knife stereotactic radiosurgery. Endovascular embolization is a common adjunctive procedure, but if the arteriovenous malformation is very large, any block resection is indicated. A patient with hydrocephalus, definitely he need shunt. Like in ischemia, there is supportive measure for intracellular hemorrhage. Hyperglycemia should be treated. Antibiotic should be administered for fever. We should avoid hypoxia. Care should be taken to prevent deep venous thrombosis. And you should remember, if a patient with intracellular hemorrhage develop deep venous thrombosis, we are really in trouble, because you cannot treat with anticoagulant any patient with intracellular hemorrhage. So it will be highly distressing on those patients, and the possibility of pulmonary embolism is high because we leave the patient without treatment. So prevent this problem rather than to get this problem, get this disaster in general. Early mobilization or rehabilitation is desirable. Okay, this is about the intracellular hemorrhage. We have two other subjects, vascular cognitive impairment and later on cerebral venous thrombosis. Vascular cognitive importance, you should remember that the second common cause of dementia nowadays after neurodegenerative diseases is multi-infarct dementia or general vascular dementia. Maybe there is no general agreement, but it's well known nowadays that each one may coexist the other. Yani any patient with neurodegenerative may be aggravated by any vascular insult, and any vascular insult may be aggravated by neurodegenerative. So there is something called mixed dementia. Vascular cognitive impairment may be subclassified into post-stroke and non-stroke vascular cognitive impairment. Post-stroke, if there is, it may have another synonymous called multi-infarct dementia. So you should recognize the significance of a treatment to prevent further stroke, because recurrent stroke may lead to vascular dementia. A multi-infarct could be large stroke, median and large artery stroke, and maybe lacunar stroke, small vessel stroke. Any recurrent can cause lead to dementia. What is ischemic stroke? Ischemic stroke is volume loss. Yani for each stroke there is a dead tissue. الثانية dead. يعني maybe the impact of paralysis is very distressing in acute stroke, but accumulation of non-motor is also distressing. It can lead to cognitive disturbance. The non-vascular stroke, the non-vascular stroke may be also related to the small vessels and called Binswanger disease. the steady progressive small vessels obstruction, deep-seated. There is a criteria to diagnosis, maybe it's not criteria, features suggest diagnosis of multi-infarct dementia. Not reach the level of criteria, but the diagnosis of vascular dementia was highly suggestive with these features. The onset of cognitive deficit associated with stroke. Abrupt onset of symptom follows stepwise deterioration. There is a deterioration in this patient, deterioration in stepwise. There is a dipping, then a plateau, dipping, then a plateau. The finding of neurological lesion consistent with the prior stroke. Infarction on cerebral imaging, and this is very important. You cannot diagnose vascular dementia without with normal neuroimaging. The clinical presentation varies with the location of the infarction. يعني أصورها قلنا. Identifying the treatment of vascular stroke is to identify and treat the cerebral vascular process. Recovery of cognitive function is not likely to occur. Memantine is the high efficacy treatment for vascular dementia. The last subject in this lecture will be cerebral venous thrombosis. This is venous stroke rather than ischemic stroke. Here something is different because the obstruction of venous sinuses can give, although it is we put venous stroke under the umbrella of stroke, the presentation is have disparities and sometimes diversities and may mimic other neurological problems. Venous stroke, venous sinus thrombosis, venous thrombosis in general, peripheral veins and venous sinuses divided into two types, septic and non-septic. It should be differentiated because the treatment is different. Aseptic thrombosis can affect the cortical vein, dural sinuses, and deep vein. The most common sinus involved is sagittal sinus followed by lateral sinus. Cortical veins rarely involved in isolation. It's usually the cortical vein associated as an expansion of the thrombosis from the sinuses. Spread the thrombus to the cortical vein resulting in venous infarction, which is hemorrhagic in about 40% of the cases, result in focal neurological deficit and disturbance of consciousness. What is the etiology? Is it the same for ischemia? Definitely not. The most common etiology behind venous stroke is raised estrogen level in women associated with pregnancy, puerperium, and contraceptive pills. Other factors include dehydration and hypercoagulable state. 20% of the cases of venous thrombosis, no etiology is detected. The frequent manifestation of venous stroke is headache, seizure, disturbance of consciousness, focal sign, optic disc swelling. Hence, cerebral venous thrombosis should be considered in the differential diagnosis of patients presented with different ways. Severe headache may be the only manifestation of venous stroke, and there is a special kind of headache called thunderclap headache. Thunderclap يعني الرعد, sudden severe headache. This is raised the possibility that this is vascular, and one of the vascular is venous stroke. Seizure disorder, disturbance of consciousness, stroke, acute meningoencephalitic syndrome, like meningoencephalitis, isolated intracranial hypertension mimicking pseudotumor cerebri. When in any nowadays in any patient with pseudotumor cerebri, we exclude the possibility of venous stroke before start treatment. Cavernous sinus thrombosis is a special entity because septic cavernous sinus thrombosis is more common than non-septic. Non-septic cavernous sinus thrombosis may follow head injury thrombosis within the dural venous arterial dural cavernous arteriovenous fistula. Usually it is septic, and from this danger area, any infection in these danger area is the drainage of the venous drainage of this area is toward the sagittal sinus. So sorry, cavernous sinus. Cavernous sinus, and may be the cause of septic cavernous sinus thrombosis. What is the treatment of venous stroke in general? The accepted treatment of intracranial venous thrombosis is anticoagulation, whether hemorrhage is present or not. The evidence for this is controversial until now, and many authors give anticoagulation even the thrombus is expanded and there is venous to the cortical vein and there is hemorrhagic infarction. Hemorrhagic infarction, I mentioned that there's 40% of hemorrhagic infarction is 40% hemorrhagic from the all infarction, and many authors give anticoagulant even there is hemorrhage. Maybe if you say 40% hemorrhagic, so the liability to be hemorrhagic is very high. يعني يمكن ستة راح تفكرون انه اوكي فاي 30% احنا ننطر 60%. This is not the case. The issue that if you have 40% in total, so any patient have high liability to be hemorrhagic. And hemorrhagic if the thrombus expanded the cortical vein outside the venous. So those authors who are fun for anticoagulant give the excuse to start anticoagulant in hemorrhagic patient that this is the indication why they have hemorrhage, because the thrombus is expanded outside the sinus, so you should give anticoagulant. But this is controversial until now. يعني ممكن ثاني طالب بورد وانا نحكي بالموضوع هذا الكونتروفيرسي until now, until this moment. So I will give it to you, and I say there is no general agreement. Our policy following venous thrombosis is to anticoagulate for 6 months. For longer term, if a persisting reason for hypercoagulability persists. Patient with cerebral venous thrombosis and suspected there is septic thrombosis rather than non-septic, he should receive appropriate antibiotic and surgical drainage of purulent collection of infection source associated with cerebral venous thrombosis when appropriate. Subdural empyema, drainage collection within the paranasal sinuses. and thank you very much for your kind attention.